Hello, everyone, and thank you so much for joining us today. My goal is to talk a little bit about the epilepsy and women. But before I begin, I want to thank you, thank the organizers for inviting me to participate to celebrate Purple Day around the world. I think it's so important that we continue to spread the word, continue to talk about educational initiatives. So today I wanted to do epilepsy and women. My name is Blanca Vazquez. I'm the director of the epilepsy program at NYU Langone, Brooklyn. I do clinical trials, and I am also the director of the international epilepsy program for NYU Langone Medical Center. It is my privilege to be able to talk about what I do every day. I have no disclosures for this talk. At NYU in New York City, we are very involved in epilepsy care for women across the reproductive ages. The critical points in the life of a woman in epilepsy are all outlined here: pre-puberty, sexual activity, planning a family, pregnancy, and postpartum. And so when I look at this spectrum, it's really an immense amount of education that we need. So I think that when you talk to your doctors, you should be always thinking, do I have a daughter that is in the pre-puberty years? Do I have a family that I'm going to plan? And planning includes prevention of pregnancy as well. Is it after the baby's born, and exactly where you're at and what questions you're going to ask is very pertinent to where are you in that timeline. So my aspiration is to cover contraception, to cover about menstrual irregularity, fertility, ovulatory function, pregnancy, breastfeeding, menopause, and bone health. But it really is going to be more sort of a taste of what we're doing. And we're very active in the epilepsy community, trying to address areas where we're going to be able to answer more questions every day because of what we do, preparing and educating women with epilepsy. So the old view of the world, and I have to thank Dr. Jackie French for allowing me to use these slides, because she has give us a perspective. In the old world, and there were very few anti-epileptic drugs. We were more concerned about teratogenicity for the baby, and the selection of anti-epileptic drugs or anti-seizure drugs, that's the new terminology, was all about teratogenicity and protecting the baby. But in the new world, we have more options, right? We have an expansion of different anti-seizures medicine, and teratogenicity, or the effect on the developing baby, is still very important. But we also have to worry about drug-to-drug interaction. We have to worry about the birth control interactions, fertility. We have to also worry very much about prevention of seizures during pregnancy. To me, that's the most important part that we should all concentrate. What is the drug that is going to keep this young woman seizure-free throughout the pregnancy? So it's a complex sort of formula, and one that really doesn't happen when the patient is pregnant. It really has to begin as a conversation before conception. And I think it's key that we do that with plenty of time, so we can make adjustments and see if that one drug is going to be the drug that is controlling the seizure, does not have side effect, and allows for a very safe outcome. All right, so there are some drugs that are more obvious that we don't want to use during childbearing, because they're very difficult for the child when the baby is being developed. And so we know that valproic acid, it has a lot of teratogenicity. It's associated with polycystic ovary syndrome, menstrual irregularities, bone loss. There are other drugs, enzyme inducing drugs like phenytoin, barbiturates, and carbamazepines that are associated with sort of increase in the binding globulin, leading to more testosterone, androgenic characteristic of the woman, and we don't like because it can affect sexuality, and it can also affect the ability to conceive. It also affects vitamin K, increases the risk of bleeding in the newborn, also causing osteopenia and osteoporosis. And these drugs are also associated with birth defects and teratogenic effects in the newborn. So let me give you one example. Carbamazepine, how does it affect the sex hormones? Well, it changes the makeup of a woman. It lowers the sort of the steroid components. It increases the binding steroid hormone globulin, and it also has a great impact in lowering the free androgenic index. So all that, it's really making an impact in the balance of hormones that a young woman needs to have to be able to conceive and to be able to have a successful conception period. So this is a 5-year follow-up study looking at girls with epilepsy, in where we measured testosterone, which is the boys or the male or androgenic hormones, and it significantly increased when you look at controls. So controls supposed to be 10, and down here, that's a normal. This is epilepsy patients that are not using any anti-seizure medicines, and this is way above what it should be when you're using a drug like valproic acid. It is slightly increased with carbamazepine, oxcarbazepine, not increased with lamotrigine. So this is looking at how does hormones change just by adding a medicine. So all this plays a big role in what I do when I try to pick the right drug for my patient. We do know that valproic acid and the enzyme-inducing drugs are associated with a syndrome called polycystic ovary syndrome. For women across the reproductive years, it is going to change the ability to get pregnant. It's going to change the makeup of the hormones. It's going to be associated with ovulatory dysfunction and menstrual irregularities. So we definitely want to stay away from that. These are the drugs that can cause a lot of the extra hair on the face, like male characteristics, acne, more central obesity, baldness. So these are all characteristics of having too much of the male hormones, and that is changed by the interaction of the drugs with the reproductive hormones in your system, and it's affecting sexuality, menstrual regularities, and also fertility. So another study looking at a 5-year follow-up in girls with epilepsy, a big chunk of them taking valproic, as you can see here in this graph, are going to have this polycystic ovary or polycystic ovary syndrome. So it's not something that it's minimal. As a neurologist, I always ask my patient, tell me about your menstrual cycles. And you may say, oh, but she's not in that specialty. But reproductive health begins in the brain, in the central nervous system. It is where the hormones are secreted for all the reproductive system. So that's why it's so important for women to talk to your doctor about menstrual cycles. And when we talk about a woman that is taking anti-seizure medicine, we want to talk about contraception, fertility, pregnancy, and pregnancy preparation, and what do we do after that? And there are 2 drugs that we use a lot in women across the early years, because we want to get them on these drugs if they're effective, because they're better tolerated in women of childbearing age. So it's a very important conversation to stay in that therapeutic range. So drugs that are going to protect your seizures, if your hormones lower that level, you're at risk of having seizures. So the lower level will put your risk of having seizures And if the interaction with the hormones is that it increases the level, then you're at risk of having toxic side effects, too much of it. So always keeping that balance is very important. So the choices to prevent pregnancy in women with epilepsy is endless. We like to talk about contraceptive pills, injectables, patches, all of those are hormonal contraception. We also have barrier methods, not as effective. Intrauterine contraceptive devices, those are the IUD. Some of it also have hormones that really do not affect the levels of lamotrigine. But these are the choices, and I tell all my women when they are not planning to get pregnant that this is a very important conversation, because I want you to know that yes, you can use contraception, and yes, we can make the adjustment with the medications that you take to prevent unwanted pregnancy. It is very important to me. And so lamotrigine is one of the very, very important drugs when you add contraceptions, because the metabolism of lamotrigine is increased. So if you have a good seizure control taking 300 milligrams of lamotrigine, as you add the oral contraception, you may need more lamotrigine because it gets out of your system faster. So all this is looking at a study where the baseline lamotrigine level was about 8 days after you start the combination with contraception, and it lowers your amount in your body. So it's not a small interaction, it's a serious interaction. So when we look at other drugs, then we look at, well, are we making the anti-seizure medicine effective, but is the contraception going to be effective? So we have a list of drugs that can lower the efficacy of the oral contraceptive pills. So another conversation to have with your doctors. These are medications that at certain levels can make you less protected, and you don't want to have contraceptive failure because that can translate into having unwanted pregnancies. So when you take a medicine that is an enzyme-inducing drug, like carbamazepine, phenytoin, and barbiturate, you have to talk to your doctor and ask, is this going to interact with the oral contraceptive protection and the birth control pill? So what is the woman with epilepsy going to face when you have this discussion? Well, you have to be very well informed, and just doing this, listening to this presentation could be the beginning to bring to your doctor what is going to be my next step when I want to prevent pregnancy. And it's very common that women with epilepsy will have unwanted pregnancies because they didn't talk to the doctors. And it's also common that women with epilepsy start contraception and boom, they have seizures when they were perfectly controlled because they lower the anti-seizure levels, anti-seizure medication levels. So these are the long-acting reversible contraception. We call it the IUDs, and there are different ones, and you need to discuss this with your GYN. So the management before pregnancy is very complex. Choose the right drug. Make sure that you need to be on anti-seizure medicine. Some ladies may be outgrowing their epilepsy syndrome and they don't need to stay on medicines forever. Take the right amount of supplementation for folic acid and multivitamins. We say up to 4 milligrams a day for folic acid. Establish the lowest possible amount of medicine that you can stay on without having seizures, so you don't expose the baby to more medicine that you have to. And work with your epilepsy specialist to make sure that you're taking one medicine if it's possible. So we do know that the combination of medicine may be more difficult to the unborn child, and it's more associated with higher risk of birth defect than if you're able to go to one drug instead of a combination. We talked about folic acid supplementation, very important. And it's associated with decreasing in birth defect for women of childbearing potential. It's also associated with better IQ for the unborn child. So this is looking at Dr. Mader's data in the place that when you look at IQ, the girls that took folic acid pre-conception, before they were pregnant, had babies that had a higher IQ. So I'm just making a very strong point for you to look at. If you didn't take folic acid, your baby IQ is lower, even though you took the same medicine. You took the same medicine, lamotrigine, and if you didn't take folic acid, the IQ is going to be lower. So we all want the kids to be in this category where the IQ is higher. So always take the folic acid, even if you're not planning to get pregnant. I think it's a key message that most pregnancies are, possible to happen when you're not really exactly preparing. So I tell all my women to take anti-seizure medicines to start taking folic acid and multivitamins before they even plan to be pregnant, in the event that you have an early conception. So catamenial seizures refers to seizures that are more likely to occur during your menstrual cycle. And we do have a lot of patients that have that predisposition to having more seizures. 30 to 50% have some increase in seizures around the menstrual cycle. And it's not always during your menstrual flow. It could be at the time of ovulation. So not only during menstruation, but at the time of ovulation. So keep a calendar. If you're having seizures around your menstrual cycle, you need to talk to your doctor. We can do different things. So sometimes we have to give you a bonus dose of anti-seizure medicine. Sometimes we need to give you other medicines that will take you over that period without having to have breakthrough seizures. And in some patients, natural progesterone for women with regular menses can be the way that we can bypass that bump during your menstrual cycles. It's called catamenial because katos means monthly, and it's the epilepsy being exacerbated by all these changes in the hormonal cycle. So now we're going to talk a little bit about epilepsy and pregnancy. There are many challenges. The goal is always to have a normal pregnancy outcome. So when you converse with your doctor, you want to talk about what are the risks of the medicine for major malformation of development, for development autism, for lowering the sort of the IQ, and then what is the risk for the mom and what is the risk for the baby, right? So we want to make sure that that we don't have any seizures during pregnancy. And why is that? It's because there is a great risk of maternal injury. There's a great risk for the baby, and there is an association with maternal mortality. So the challenge is to maintain a balance that is going to get us through safe pregnancy, no seizures, safe outcome, no malformations of development. So this is looking at different drugs and how they sort of behave during the pregnancy. And it's important to know that the amount of medicine that you take when you start your pregnancy is going to change at the end of the pregnancy, because all the hormones are going to change your metabolism. Metabolism means that your seizures may be more active if you don't increase that medicine. So I tell all my patients that they have to do every 4 weeks, they have to take a blood test, and the blood test is going to tell us how much medicine is in your system. And with that, you will be able to maintain a level by adjusting the dosage of the medicine. So a lot of the women say, but I don't want to take more medications. But actually, your body is keeping less and less. So even though the milligrams are more when you're taking the medicine, what keeps inside, what stays inside to protect you, it's going to be the same. So it's a process that you need to understand, because this is looking at lamotrigine. Look how much the variation across the pregnancy between the pre-conception, when you start pregnancy, and when you get to the end of the pregnancy. And so it could be as high as 350% different. So be mindful of that and talk to your doctor. So the risk of seizures is great. All the seizures can happen during pregnancy if we don't maintain an eye on these variations. Status epilepticus, it's a condition where seizures don't stop one after another. And these can all be prevented if you maintain the levels of medicines by checking your blood test every 4 weeks, and that will help. So the impact of maternal seizures are many. It is very important that you keep an eye on that. And I think that it's key that this conversation begins prior to conception. So if you never spoke with your doctor about it, it's a good time to bring it up. Pregnancy and complications during pregnancies, there are many. During the early part of pregnancy, the 9 weeks of the pregnancy is where the baby is developing. And then at the end, we worry about other things like during the birth and how do we prevent complications. And the choices of the medicines will have to do with how we manage all this. There's a lot of literature on outcomes and malformations of development, and every drug has a risk. Here we look at levetiracetam, which is one of the lowest risk, lamotrigine, low risk, versus other drugs like carbamazepine, phenytoin, and valproic acid that have much higher risk of malformation for the baby. So that's why talking to your doctor, yes, doc, in the next 2 years, I want to get pregnant. It's a big deal because you need to do a clear assessment to see what is the right drug to undertake this. Is this the group that you want to be in with the lower risk of malformation, or is this the group that you want to be in with the higher risk, with the valproic acid versus levetiracetam, lamotrigine, and carbamazepine? Also, the amount that you take, the dose, it's very important to manage that. Higher dose are associated with more difficulties. If you need to combine drugs, which we don't like to do, but if you need to, the amount that you take being a lower dose, it's probably better for the outcome. So staying on the lowest dose is what we recommend. We talk about malformation of development that can start from small for gestational age to having other malformations of development. Lower dose, I think I made a point here, it's what we try to illustrate when we look at other things like autism and how its association with the higher dose are there. So we're done with the pregnancy, and now we're going to talk a little bit about breastfeeding, which is very important to know that it is allowed to breastfeed your child because of the benefits of breastfeeding. And you should talk to not only your doctor, GYN, your pediatrician, but your epilepsy doctor, because this is a conversation 3-way, and everybody has to be in the same page to say that when you have your baby, yes, the baby was exposed during pregnancy, and now with breast milk, it's going to be a lower exposure. So it is associated with better IQ. It is associated with better maternal bonding and maturity and other things that are beneficial for the baby and the mom. So just we're getting to an end. So what is the safe anti-epileptic drug during pregnancy? All the drugs have risk. Some of them have a much lower risk, and those are the ones that we recommend. Some other ones have more risk for major malformation of development. We try to stay with one drug and not combine different anti-seizure drugs to decrease the risk of malformation of development. And yes, breastfeeding is definitely associated. with allowed during sort of for mothers that are planning to do breastfeeding. Women treated with anti-seizure medicines need to look at conception when they want to prevent pregnancy, monitor bone health, because some of the drugs that we use for controlling the seizures can also affect the bone health and put us at risk of fractures, like the enzyme-inducing drugs and valproic acid, phenytoin, carbamazepine, and phenobarbital are associated with high increase of osteoporosis. So we usually like to do that bone density studies to try to prevent any risk of bone density changes. And this is something that happens throughout your life. So it's not just, oh, I had it done when I was younger. Every so many years, your doctor may need to recheck to prevent any monitoring concerns. I encourage everyone to register in the pregnancy register, because this is the way that we gain all the information that I presented to you today. And this is the way that we enjoy the benefit of preventing problems for women that come after you. We need to consider the effect of hormones on the anti-seizure drugs, but also the anti-seizure drugs on the hormone. It is not just about pregnancy, it's about wellness. We didn't have time to talk about mood, but women with epilepsy would also have mood changes that can be associated with the choice of the medicine that we use. We also can see mood changes that are associated with the postpartum period. We can associate depression, anxiety in patients with epilepsy. It's a high comorbidity that occurs in patients with epilepsy. So talk to your doctor about mood, talk to your doctor about sleep, not just women in epilepsy, but sleep is the #1 reason why people are having breakthrough seizures. They don't sleep enough, they were up all night with the baby, they can't sleep, the medicine is affecting sleep. All that can be very important with your neurologist to have that conversation. There are multiple choices of medicine, so you don't have to stay with one. If you're getting ready to conceive and be pregnant, you can't have other choices. The goal is always to stay without seizures. I think we're just about out of time, but I think this is a very attainable goal, not just for women with epilepsy. We have so many different choices today. We have drugs that work in different mechanisms. So for women with epilepsy that have other problems, head injuries, memory problems, sleep problems, mood disorder, weight gain, all those things, there are many things that we can help you with the right selection of anti-seizure medicine. I want to say that this has been a great opportunity to talk about not only what I do every day, but what the epilepsy community is doing to educate women, to advocate for not just pregnancy, it's women across the reproductive years. I didn't have a chance to talk about the menopause, but women with epilepsy have a lot of questions after menopause as well. And how does that change in the hormonal makeup? It's going to affect the seizures. So I think it's great that you are engaged and you want to get educated about issues that are important to you, women with epilepsy. Thank you for your attention today. And I really hope that you enjoy my presentation as much as I enjoy presenting it to you. Thank you.